I'm a paediatrician by background, but I've been in research for a long time. I was asked to come and give this talk because I'm involved with the FAR Institute of Health Informatics Research. I lead the maternal and child health theme for the London Centre, and I'm also a deputy director of something called the Administrative Data Research Centre for England, which is about linking data from public services across government departments. So I'm going to give a talk about our national data resources, which are pretty basic for you because you have such rich data here in Denmark. And then I've asked Johnny Downs to come and tell about the sort of local initiatives that are much richer for joining up mental health data. I should also say before I start, thank you for speaking English so brilliantly. We take it for granted, but it is amazing that we can do this meeting like this. Okay, so there's been big investment in the UK in big data. We're in the middle of 5-year funding at the moment for health informatics research and medical bioinformatics, so for the Genetics England and the eMed Lab, and then the FAR Institute. The MRC, our Medical Research Council, spent about 120 million on that. And then for the Administrative Data Research Centre and a smaller amount on business and retail and local government expenditure. There's been a lot of money spent on this, and they're looking to more spend in the subsequent 5 years. So we have, for these two, this one and this one, we have 4 centres around the UK, and particularly for administrative data, that reflects that we are devolved governments. I'm going to be speaking mainly about data from England, which is 85% of the population of about 60 million. But there are centres with actually much richer data in Wales and Scotland. Scotland is about 5 million, Wales is about 1.5 million. So I'm going to give you some examples of our data, and I'm going to talk mainly about our 2 best health data sets. One is hospital episode statistics in England. All these figures are per year. So you see that we have a lot of data per year, 14 million inpatient admissions. I'm giving all the web links because there's a lot of detail that some of you might want to look at. The value of this is that it's longitudinal data. So we can take people that come into the service at say 15 with a self-harm episode, and we can follow them up to age 30 and see how much they come back into hospital or whether they die. I'll show you an example of that. The other gold that we have is primary care data, but this is only for a subset of the population. This is whole country, so we can create whole country birth cohorts, for example. This is just for different data sets, but 6 to 11% of the UK population. So at any one time, we have about 4 to 6 million active patients. Costs are different. All of these data sets can be applied for from within the EU. A full copy of HES will be about 10 to 15,000 pounds. A full copy of CPRD will be about 130, 150,000 pounds. So it's very expensive. The other data sets we have are registration data and then intensive care data, but I'm going to focus on these. All can be linked together. Okay, so an example that we've been involved in using hospital admission data, looking at the whole longitudinal record, we can see that 4% of adolescents are admitted at least once to hospital for injury related to, we've called it adversity, violence, self-harm and drug and alcohol. we traditionally think mostly about this group needing psychosocial assessment before they leave hospital, but these are just as common, and our work has shown they have a very similar prognosis. And they don't breed true. These do not necessarily then come back in with self-harm, they come back in with this, and they die of different things. So I'll show you, so for instance, when we follow up to 10 years later, this is something you'd be able to do in Denmark to compare. 1 in 75 boys are dead after hospital discharge, after being sent home well, within 10 years. And if we look at the 18 to 19-year-olds, 1 in 50 will be dead, slightly lower for the girls. And what we see is that regardless of the type of injury you come in with, the risks of dying from suicide or drug or alcohol related deaths are similar. So when you're thinking about preventing subsequent deaths, it's just as important to think about drug or alcohol related deaths, or actually a third of the deaths will be accidents or due to other things, than just suicide. So it really changed, this ability to look across the whole population changes your view on who we should be prioritising, this is a high-risk group, and what we should be trying to prevent. We have a control group here, a comparison group of those who came in with accident-related deaths who are much lower risk. So this is the risk scale here. Okay, so that's one example. Now moving to primary care data. This is from a study that was published this year, and some of you in the audience may have been involved in this. So we use primary care data to look at, in any 1 year, children prescribed antidepressants. And here's Denmark and England following very closely. So the most recent, and increasing, so the most recent data is about 1% of children in both countries. And of course, if we look at that for the older age groups, it's that the percentage will be a bit higher. And then here's another example of the enormous value of the longitudinal record in primary care data. There are problems with this because the record only lasts while they're registered with that particular practice that is in this data system. So that is problematic, but we can start to look at families. And I think if David talking about the community, I think here is where record linkage of administrative data can start to allow us to look at the health and use of public services of the community that is the family, linked by household identifiers. So what's very exciting for me as a paediatrician is we can look at exposures in pregnancy, or in fact a lot of the history of the mother and how that might relate to childhood outcomes. So here's linkage to the father is a bit more difficult. We're linking on a family identifier, so it's basically the man in the house at the birth. But for instance, there was a study done, published in 2010, that showed when you followed up this triad up to 12 years, then what you saw was that 39% of the mothers and 21% of the fathers had either a diagnosis recorded in their primary care records or 2 courses of treatment of antidepressants by the time their child was 12 years old. So my children are over 12 now, and I wasn't in that group, luckily, but it's very, very prevalent. There we are. So the other gold that we have in England is the education data, which is fantastic. Most of it going from 2001 onwards, some of it going back to 1996. We're dealing, this is for England and Wales, so around 700,000 children per year, relates to state school pupils, and it has masses of information on all their school assessments, absences, exclusions, special educational needs. It's been used quite extensively for a long time, and I'm sure people in this room have used it. Less well trodden is our children's social care database, which every year about 6% of children are referred to social care services, of all children, and about 3 to 4% have an assessment and have some follow-up. So it's a reasonable portion of the population, but the data hasn't been used that much in research. We also have higher education, and something we've been using a lot, because I've been very interested in child maltreatment over many years. We've been using the looked after children data, which is again longitudinal and actually from 1992 onwards. So I'm going to show you some data comparing England and Denmark with this data. So here we have age going up to here, and for children born in 92 to 94 we can follow them till they're 18, and by the age of 16 nearly 3%, 2.9% of children have been in out-of-home care at least once. And it's really interesting to see this sort of blip up in adolescence. So there's much more use of it in adolescence. But as we go to the more recent cohorts, so these are children born in 2009 to 2011, the rate is increasing. We're using out-of-home care services much, much more. And if we continue that line on, of course, it's going to be a lot more than 3% that ever enter out-of-home care. That's a very expensive service. And as we've heard, some of it will be institutional care, and there's issues about how therapeutic that is. So here's the data for Denmark, same period. The publications are up there. So in Denmark, 3.4% had entered care by the age of 16, but a very different policy is going on here. So as we look at the more recent cohorts, entry into out-of-home care is getting less and less. And the point where we're making a big difference, which is at infancy, there's huge pressure to place children in out-of-home care early. There's now a requirement that you do that within 26 weeks. So we've gone from 0.5% to 0.8%. So our big jump is here. No change in Denmark. So I think these offer natural policy experiments where there really is mileage in looking at Denmark and the UK to see, well, so is there a problem in Denmark in that you're failing to deal with all these children who should be going into care? Or are we doing something wrong? So we need, I mean, of course, there's problems about using administrative data like this, because out-of-home care in Denmark may mean something different to in England. But I can tell you that when we follow these children, they're getting longer stays, less frequent changes, so that's very good, but much longer stays. So lastly, child and adolescent mental health data, and this is not a great story at the moment, which is why I've asked Johnny to talk about the local initiative. So we don't yet have national child and adolescent mental health data. It's expected to come online for England from 2017, but we always have to be very wary about new data sets. They need time to bed in and to be used and for glitches to be solved. We do have adult mental health and learning and disability from 2014 onwards, so that's outpatient data. Again, a lot more expensive than the standard HES data. And we have Miranda Walpert from the Cork Initiative is collating a lot of self-report data from mental health services, whether they be from health services or voluntary sector or in schools. So the websites are there. this is just worth looking at. It's a lovely website which gives you basic profiles using aggregate data of child health and well-being, but not individual level data. So I'm now going to hand over to Johnny Downs, who's going to talk about the local initiative. You've got a microphone. Okay.